Welcome Internet to psychoanalytic cogitation, and today I'm going to talk about a very heated and problematic question, notably the question of diagnosis and its purposes, its uses, and how it can be very complicated to navigate, both for the patient and for the clinician. So, first and foremost, we have to really go into, before we start, into the question of diagnosis. So it's a loaded question because depending on the country, there might be a lot of paperwork involved, or administrative reasons, or health reasons. For example, I think that in the US, the diagnosis is useful to get reimbursement for therapy or to prove another health condition. In France, it's a little different. The diagnosis does not condition repayment for therapy if it's done by a psychiatrist. So it's quite different setups. But here I'm not going to really delve into that, even though it's interesting questions. Because I work in France, I'm not necessarily confronted to them. So keep them in mind. I just want to tell you that they exist for administrative reasons, for, let's say, insurance reasons, and so on and so forth. But I'm not well versed in those, so I'm not going to delve into that so much. So what I wanted to talk about is really more the impact on the psychotherapeutic relationship of the question of diagnosis. Because often, at least how I was trained, and that's where I'm gonna start from. Where I was trained, there was that idea that the clinician should never ever bring forward the question of diagnosis with the patient. The main rationale behind it was that if the clinician brings the idea of diagnosis, it might worsen the condition of the patient. So what did they mean by worsening? They mean that the symptoms might become more extreme, that the patient might try and stick to the diagnosis, meaning that if they recognize, it might make the diagnosis their whole identity, that it's going to be, I don't know, I'm anxious, I'm depressed, I'm schizophrenic, and so on and so forth, and they might just compress themselves into that diagnosis and reduce who they are to the diagnostic elements. So that's how I was trained, of trying to avoid it at every single cost humanly possible. Working with patients for the last 10 years has taught me that I don't think it's necessarily a good solution. I do feel that for some people, diagnosis is unimportant. Like, really, some patients don't care at all. Like, really, that's not their problem. They don't really care. And they feel that it's not going to bring too much interest to know it. And that's often the more comfortable, let's say, approach, that the patient doesn't ask, the clinician is never confronted to that issue, and the therapy can live its life, right? But sometimes the patient might bring out the question, oh, what am I? And what do I suffer from? Could you tell me? Because I have ideas, but I'm unsure. And as I stated, when I was trained, the whole purpose was to try and avoid it by saying things like, oh, well, we can't put a diagnosis, not like this, not in this setting, or to try and say, why do you want a diagnosis, or try and dodge. Basically, that was the whole premise. They didn't say it quite as bluntly as what I've just said, but the whole idea was, if you get that question, you dodge it. Evolving as a therapist has shown me that sometimes there is a fundamental reason why the patient might ask for it. And the more I've come to work with people, the more interesting I've found the question of diagnosis, because it's kind of a double-edged sword. There is those risks, of course, that the patient might over-identify and say, oh, I'm fully, let's say, autistic, or I'm fully depressed, or I'm fully anxious, or I'm fully this, or fully that. But, and that's a big but, that can also help the patient try and understand certain phenomena that happen in his or her life, that they are not necessarily due to bad will or to basically a question of just choice, that it goes beyond that phenomena. And the diagnostic framing kind of gives a frame, a guideline of why these things happen, an explanation. So in itself, strangely enough, it holds a lot of meaning, a lot of explanational power on the dynamics and the suffering the patient has experienced. However, it can also be, and that's, I think, also a main problem, a narcissistic blow to the personality of the patient, meaning that the patient is like, oh, well, I just thought that was a quirk, I didn't think that was a mental disorder, and it can really like hurt the therapeutic alliance or the transference or the countertransference of the therapist, because the therapist might feel that he has faulted or that he should not have given that information to the patient. However, I think that the more and more I work with those tools, the more and more I talk about it with the patient, the more I feel comfortable talking about diagnostic elements, because even though I do feel that diagnoses are inherently reductive, because things have to fit in boxes in order for diagnosis, that's how it works. It's not something that opens up to so many perspectives, so many reasonable thinking. It's more something that boxes in, that limits the individual. Of course, there's like also a double standard, like we don't want to talk about it with a patient, but then in between colleagues we might say, well, for example, with a supervisor, with intervision, with other colleagues, when you're trying to like understand the processes, trying to understand your countertransference, you might say, well, I feel that this is borderline, or the patient has borderline personality disorder or schizoid personality disorder. And you're going to use those diagnostic elements with the colleagues as shorthand. So that's why I've always felt like on the edge, because in the community, at least in the community I am part of as a clinician in France, there is that double standard of basically it's going to be a shorthand for everyone. Everyone's going to use histrionic. All the clinicians are going to use that as shorthand. But with the patient, there is some kind of reluctantness to give one's hypothesis. And I always found that dubious. I never liked it. And I never liked the contradiction. So nowadays, what I do is that I never myself tell the patient bluntly what he is. I always, when the patient asks, take the time. I will take even sometimes 1 or 2 sessions to really explain why I think that, what are the hypotheses, and I always try and frame it, and I always do successfully, hopefully, frame it as my ideas. It's like, this is not science as like physics, where you're gonna test and it's gonna always be the same answer. And I always explain it to them that sometimes clinicians have different diagnoses. Because the diagnosis is also a focal point for the therapy. So if someone gets depression, they might have depression, but they might also have, let's say, a personality disorder or an autistic spectrum disorder or anything else, right? But the clinician is going to focus on depression. So it's not necessarily that the clinician that's doing the diagnosis is wrong, but there might be something else. And on what you take the focal point is what is going to be important. So they can be, and that can be very confusing for patients, thinking, but wait, my previous therapist said that I'm depressed, or my previous therapist said that I was borderline. So many things can coexist, and you have to understand that's why it's so complicated, really, when you get down to it. But what I personally do is that I take time to explain my hypothesis, always framing them as a hypothesis to the patient, trying to let them know that it's only my point of view, that it's not like branding. I'm not branding them this or that. It's just that I feel that they might be. And sometimes, and I think that when the patient already has a diagnosis, there's no need for an extra one, except if you fundamentally disagree or the patient has been very, very hurt by the diagnosis and it's a wrong diagnosis. That can happen. But in those very specific cases that I've just mentioned, I don't think that there is necessarily an appeal to try and re-diagnose every time or every individual detail, and only if the patient is really curious of what they have. Because I do think that there is some, as I stated earlier, some real explanatory power to but the diagnosis elements, meaning that the patient can really start to understand a new light and new lens, might open up some connections of like, oh, I understand the dynamics now, because if I'm that or this or that, or I've suffered from that, then my behavior is in a new light. Of course, one might say that it would increase bad behavior, but in my experience, that's not the case. Like, the patients don't go, like, let's say, don't hide under their diagnosis to do bad behavior. It's more that they start understanding things in a different light, that start understanding what is part of the illness or the disorder, and what is part of a more quote-unquote healthy personality aspect. So there's two elements that I feel can be regrouped, and some psychoanalysts like Kernberg have a very interesting point of view. They just give the diagnosis straight up. They don't even they say this is that, this is this, this is how we're going to work. And fine, that's good. I mean, as long as it's not a blow to the patient, or that the blow can be taken within the frame of psychotherapy, because I think that that's the main problem, is that if you're just going to throw a diagnosis to the patient, like, let's say, oh, well, you're depressed. Well, what does the patient can understand about that? Because each depression is different, and it doesn't mean really much. And if you're really going to have that talk with the patient, that talk can be so enriching, both for the clinician and for the patient. And the patient can then start asking, what is the specific type? Why is this so different from, let's say, your Wikipedia explanation of the phenomenon, or your website like the Mayo Clinic? I'm not attacking those websites, right? They're great, but sometimes they're very standardized, and sometimes you kind of need to have a more clinical view of things, rather than just a tier list of symptoms or a list of symptoms. So basically, it's very enriching, I think, that question of the diagnosis, because it's not an easy one. It's never easy, both for the patient and for the clinician, but it opens up so much, both in terms of the past of the patient, but also in terms of where the therapy can go. Because it's also, I think, something that my teachers never quite understood when I was in training, and something that I have understood myself, is that patients also start distrusting the therapist if the therapist does not provide a hypothesis. Because the patients, all of them, even people with intellectual disability, are smart. They know when you're withholding something from them, and they would not understand why, because all the other health professionals, like, for example, a doctor, is not necessarily gonna withhold information, at least not when he's pretty sure of where he's gonna go. Like, for example, a doctor's not gonna withhold, for example, the fact that he thinks that you might have any form of illness, right? They're gonna say it to you. But mental health professionals don't always do that. And that can be a cause for suspicion of, why are they holding back information? And you can always explain it. And if you explain to the patient that you're afraid that they might stick to it, I think that they can understand that. I really do. And that it's not necessarily a bad thing to explain that to them. What I do think, though, is that it has to be genuine. Like, if you don't want to give the diagnosis, fine. But you have to really explain it to them, that you're afraid that they might not be able to explore it to the fullest, or it might be too much of a blow to hear it. All of these things are completely legitimate, but they have to be talked about with the patient. So you don't have to answer basically with diagnostic criteria or with a diagnosis every single time. You can take time to think about it. And in my experience, patients are very understanding. They say, oh, okay, well, we'll talk about it next week or the week after. And then you basically told them about what you think, and it goes down well. And even sometimes, in rare cases, it does happen, when you start sharing the diagnosis, there start to be improvements. And I'm not going to go and construct a whole theory of it, right? But I think it's sometimes just the trust you've put into the patient, as they've put in trust into you, you put trust into them, and that creates a stronger therapeutic alliance, and they can understand. And I think that helps them heal also, that you've trusted them with this information, and they've trusted you with that information as well. So that's my very personal take on the question of diagnosis. As stated earlier, when there's questions of insurance, I've been confronted to it, but relatively lightly, because in France it really doesn't work the same way. But when it does happen, or at least when I've been confronted with the issue, I always take the time to explain it to the patient. That the patient shouldn't be a surprise, it shouldn't be a shock, it shouldn't be a, oh my god. It should be a, oh, okay, he told me that I had that problem, okay. And that should be I think the basis of that question, of the diagnosis. And of course, psychoanalytically speaking, the diagnosis is a complicated tool to use, because people might start identifying or throwing blame or doing research, and sometimes you can't control the research of the patient. But you can always, I think, explain it to them, or tell them why you disagree with the research they've been doing, or why, let's say, you feel that there might be more to it. Of course, this is so dependent on every single case, so it's really a case per case basis. So there's no general rule, right? There's only an individual rule that has to be changed every single time, and that's what makes it wonderful, but it's also what makes it horribly complicated. So I hope that you liked the discussion, because I'm pretty much done with this topic at this point. So if you have any questions, feel free to ask them in the comments. I'll see you in the next one. Bye.